1.5. So yeah, he's had nursery today. So it's just see him briefly in the morning and the evening, and so it's just nice to just get that little bit of time with him.
Yeah, what time does he get to sleep?
Shortly, so he typically 7:30. So I've closed the door down here, so hopefully you won't hear any crying or noises or anything. I
Hopefully
think.
you won't hear my little one as well, who's 1.5, so
How old is he?
a year and a half.
Ah, oh,
Yeah.
so nice, isn't it? Is he your first one?
No, he's number two.
Number
So
two.
I've
Right,
got an
yeah.
older girl. So yeah.
Fair dues. All right, so you know what you're doing, basically.
Well, yeah.
Yeah.
Well,
How's your day? Okay.
yeah, really good, really good. Busy with lots of things, but yeah, it's been really good.
Good. So the format for today is just you're going to give me an intro and then just crack on, essentially, right?
I'm not going to give you a major intro.
Okay.
If you can maybe do a
Self
bit of that,
intro.
that would be
Fine.
great.
Yeah, fine.
And yeah, and then what will happen is that if we can make it as interactive as possible, so people ask questions, and at appropriate times I'll kind of interject and maybe ask you questions live. Is that all right?
Yeah, I mean, okay, I've got no problem doing that. I haven't done one like that. I normally present and then question at the end, but it's
Yeah,
absolutely
I think it just makes it a little bit more interactive if the questions are kind of timely as well.
so it might work out nicely because I split it into three different
Yeah,
parts.
yeah, yeah.
So maybe that's
If you
really
want, we can hold the questions until the three parts. So at the end of each part, if you like.
yeah, and then you can it'll be relevant to that
Yeah,
specific part,
that's
right?
fine.
So
Yeah, yeah,
that's a good idea, actually. Yeah.
that's fine.
How long do we have, by the way? I don't know.
We're supposed to finish the kind of main presentation by about 8:30, and then 30 minutes of kind of questions, and if people want to hang around for a bit longer to ask you questions as well. So around about till 8:30. Is that all right?
Okay, fine. Yeah, that's I should be hopefully done by 8:30. All right. Yeah,
Yeah.
yeah.
But if you run on a bit, excellent. So I think we're.
Can you just check my screen share?
Yeah. So I'm just going to let the audience know that are kind of coming through, that any questions they have, they can just pop it into the channel, into the Q&A section, and we'll ask them live in those three sections.
Sure. Great. Are we all set to go?
Yeah, very impressive.
So
yeah, do you want me to? I'll give you a brief introduction. And then you can go through things. Is that all right?
yeah, absolutely. That's fine.
So this is Jalpesh. He's for me a little bit newer in the facial aesthetics forum, but a rising kind of star in many ways. I know this kind of firsthand because my dad's been on a lot of his courses as well and sung his praises as well. So in terms of facial aesthetics, it's something that he's one of the trusted providers for the new kind of College of General Dentistry. Is that right?
Yeah, that's right. Yeah, so that's something that the college actually officially launched quite recently, but they've sort of taken over the work from the FGDP. So kind of trying to take it to another level now, pursuing a royal charter. So it's quite really nice to be involved with the college. Yeah. So
cool. So we're going to be discussing facial aesthetics, regulations, various clinical cases, and complications. So without further ado, I'll hand over to Jalpesh, and we'll ask questions as we try and go along as well to make it interactive. Excellent.
Over to you. Thank you. So good evening, everyone. Hope you all had a lovely day today. So today, yes, as Michelle, we're talking about facial aesthetics, regulations, clinical cases, and complications. And I guess the audience, the target for this sort of presentation, is kind of targeting a broad spectrum of individuals, from those who perhaps had little or no experience to ones that might have some experience in facial aesthetics. So my journey, just a little bit of intro, my journey sort of started 8-9 years ago. I quickly sort of, after graduating, fell into facial aesthetics purely because there was a sort of a need for that at the practice I was working at, and a demand. And it was interesting because at that time, there wasn't very many prescribed pathways in terms of training. So, the culture was to sort of go on short day courses and sort of build up a portfolio that way. But there wasn't any sort of real guidance or, as I said, prescribed pathways. And it kind of really stood out to me that this is something that needs to be dealt with, really. And as I go in this presentation, you'll realize that things have sort of progressed sort of since that point. So as I was mentioning just before, again, a few years ago, we established RAS Academy, and then we sort of partnered with the college, acted as a trusted provider for them to deliver a postgraduate certificate program, which is a competency-based program. It's a flexible program, takes approximately a year to complete. Lots of hands-on clinical activity at our sites. So it's quite a nice program because it's not just a load of theory and watching sort of webinars and seminars and presentations. You're actually in the clinic, learning on patients and seeing lots and lots of patients. So it's a nice program to be involved with. And also the college, a very progressive set of people that work who are in the college, really thinking about the future of both dentistry, and clearly they've incorporated non-surgical facial aesthetics because so many dentists are now providing this as a treatment option for their patient, which is fantastic, because in an industry that overall is sort of under-regulated, it's good to have regulated professionals sort of delivering it, kind of steering the way for this industry. And dentistry has a very, very dental surgeon, dentists have a really, really important part to play. Yes, like I was just mentioning to Mish before, that the college is sort of, for those of you who don't know, the College of General Dentistry is sort of taken over from the FGDP, and now really looking to kind of fly, essentially. Today's presentation will cover, it's being split into 3 different parts, and they are sort of semi-linked, but they're quite distinct as well. So the first part is why individuals might be considering sort of providing cosmetic injectables, in dental setting or in a private setting, or and then understanding why having a structured plan to address your training and the commercial aspects of the field is more likely to result in a successful outcome, i.e. you actually, not just going on a course and then it kind of dwindling out. When you structure your training pathway, you'll find there's sort of 2 types of individuals: ones that go on a course or a few courses and then it kind of peters out. What you need to do is you need to kind of build and kind of get to a point where you're regularly providing these kind of treatments in practice as well. So this is kind of a way to do that. And then just kind of an appreciation of the current and anticipated regulatory landscape. We then move on to the second part, which is kind of looking at the clinical aspect of the patient journey, because a lot of students ask, well, how do we get more and more patients to come through the door? Well, that's important, but one of the major things is how you retain them, and actually how you when you're starting out, you might be able to kind of treat a finite amount the clinical indications, and how you kind of actually plan what you're going to do in the future once you do further training, because you don't just do all of your training at the beginning and then suddenly you're able to treat every single indication clinically. You need to kind of figure out how you're going to stage that. So we'll kind of talk about that in part 2. And then we'll look at a case where we inject in multiple sites, We'll look at the anatomy. We'll look at some videos of the injections and things like that. And then the third part is, again, for those of you who are actually involved and actually doing some injectables, we'll look at sort of identifying and managing vascular occlusion, which is one of the complications. There are several others, but this is one of the major ones that we need to be aware of. And it's just nice to either, if you aren't aware of it, just to know what it's about. For those of you who are, it's a good refresher, just to kind of remember the sort of protocols involved in managing vascular occlusion. So that's the intro. Just those of you who, just as a thank you, for those of you who are interested, we have got a little video for all of you as well of a case that we treated, lots of anatomy drawn on, et cetera, et cetera. So just to get access to that, just sign up to our newsletter on our website. The website is at the bottom here, www.rasacademy.co.uk, and then you'll get a link to the video. So I'm just going to really briefly, for those of you, because again, we've got a spectrum in our audience, those of you may not have injected before and done any sort of facial aesthetic treatment, just give you a very, very brief intro into facial aesthetics. So it is a spectrum of treatment modalities. There's lots of things that are incorporated into the facial aesthetic spectrum. From creams, peels, lasers, etc. But what we're going to be focusing on today is the cosmetic injectables, so botulinum toxin and dermal fillers. And the true indications of these things are to sort of address and soften age-related changes. And so, again, talking very, very, very simply here, botulinum toxin works on relaxing muscles, essentially. So over time, we sort of develop an inherent tone in muscles of facial expression, and by relaxing them, those sort of lines sort of soften. And dermal fillers works to kind of replenish lost facial volume. So we have both superficial and deep fat pads, and they sort of become atrophic and migrate over time and lead to these sort of age-related changes. And you can use dermal fillers to help mitigate against those changes. So there is a finite amount of things that these things can do, but done in the right way, it can give really nice, natural-looking outcomes. So lots of dentists moving into sort of facial aesthetics, offering these kind of treatment modalities. It's essentially, something different to do. It's a non-AGP, so that's quite nice. You don't have to pop on the FFP3. There's some financial, incentives or benefits from doing. I don't think that should be the number one reason why you do this, but it is, if done well and you've developed a nice list, it can be quite rewarding financially. There's also adjuncts. You can use botulinum toxin and dermal filler adjuncts to dental treatments, patients bruxing. You want to inject the masseters and temporalis, can be done. Gummy smiles. Patients who've got skeletal class 2s, for example, you can augment in the lower third of the face to kind of give some profile harmony. So there's all sorts of things that can be done in that respect. And then I guess it opens up the doors, because you can work in dental settings, you can work in skin clinics with dermatologists, et cetera. And treatment times actually with facial aesthetic injectables, it doesn't take terribly long. So actually you get a lot of time with the patient, because there's a lot of rapport building, et cetera. So it's quite nice and relaxed in that respect. And we've actually got a lot of skills as dentists that is transferable straight away. If you compare yourself to someone who's never done anything clinical, essentially. So, we've got the clinical skills, injecting, although we inject local anesthetic, they're injecting on the face and it's slightly different, but you've got some basic skills in that respect. We know how to deal with emergencies, not saying that that's a frequent occurrence, but obviously we need to be aware of that. We have an understanding of anatomy of the face. So that again is a massive, important part of facial aesthetics. We understand and appreciate the importance of a patient assessment, understanding how that can almost act like a filtering process to kind of see who patients that are indicated for treatment, those aren't, as opposed to just everyone is indicated situation. We have an aesthetic eye. I mean, a lot of us do cosmetic type dentistry as well, and your eye becomes more refined over time. If you compare yourself, if you do this kind of dentistry, that how you were treating, say, 5 years ago, you do become more refined in the way you see things, and that's important because essentially, if your expectations are higher than your patients, then you're onto a winner. And then we've got the importance of infection control, which nowadays patients are really becoming more aware of course, with the pandemic and COVID, etc. So there are lots of dentists, many of you potentially, who are involved in facial aesthetics or want to get involved in facial aesthetics more so. And so I think the first part we're going to talk about is regulation and training pathways, because I guess what you need to know is what the expectation is in terms of training and the ways you can do it. This is what was not available to me when I started training myself several years ago. So hopefully this will help. And it all comes down to this, essentially. There is no injectable procedure without risk. So the thing is that with facial aesthetics, there's this, some people make it synonymous to sort of beauty type treatments. Now, the thing with a lot of beauty treatments, the risks are incredibly low, or there are no risks. Whereas with injectable procedures, there are risks. Things can happen, and they can be adverse outcomes. So what's the realization is that there is a risk profile to this industry, and so it can't just be open to everyone and anyone to do, because if there's a risk of complications, then there needs to be a way of managing those complications. And then the question is, who can manage these complications? So as medical professionals, we're in a really good place to be able to understand what they are and also manage them as well. So there's a whole there's lots of different types of risk and complications. Things that are like potentially more common, but not very severe, like bruising, all the way to sort of things like vascular occlusion, which we're going to sort of talk about later on in the presentation. So you need to have essentially a systematic way to approach these risks and to reduce risk. So you need to have a comprehensive assessment, and you need to be competent at doing what you're doing. So you need to have an awareness and a competence to what you're doing in facial aesthetics. So if you have been trained well and you know what you're doing, at the treatment stage, you're less likely to get a complication. Again, if you do get a complication, but you train well, you're less likely to get a permanent adverse outcome. So what you don't want to be doing is going down this pathway very quickly. So the question we have to ask ourselves, how competent are we? What's the benchmark? Where do we stand, essentially? And so just to give you a bit of history about the regulation in the industry, and then tie that in with that concept. So in 2013, the Keogh Review is a very big review, which was published by the Department of Health. Now, basically, it just essentially said that the cosmetic injectable industry is very, very poorly regulated. Patients don't have the sort of protection required. But it also outlined that actually the training pathways were inadequate. So the issue is that no matter who you are, whether you're a doctor, dentist, or a beautician, or whatever it was, whatever you are, the training pathways are not very well prescribed. They're not. It's very difficult for someone, like I was saying for myself, for example, to know exactly what needs to be done. So what happened was there was a number of stakeholder meetings, 2015 and prior to this, and a document was released by Health Education in England, which was qualification standards. So this was actually a very broad baseline of framework of what a practitioner would ideally need to know and be able to do prior to actually injecting independently. And then this work all got taken over by the JCCP, the Joint Council of Cosmetic Practitioners, who effectively are like, they're synonymous to the GDC, but they're a voluntary regulator who, so you don't have to be you don't have to be a member with JCCP, but what they do set is a competency framework. So they basically say that practitioners should be able to do X, Y, and Z. And they do this for their training, for the training pathways as well. And incidentally, JCCP have memorandums of understanding with various bodies, including the GDC. So they all kind of singing from the same hymn sheet, so to speak. So it's a good reference point to look at. So they have a register of individuals who who are compliant with their regulations, and they have a training of a competency framework. So what that means is that they've got a framework which basically outlines exactly what you need to know from your training pathways. Now, more recently, there's been in the last couple of months, all-party parliamentary group in beauty and aesthetics and well-being, that there's been a big meeting which basically outlined that there's further work that still needs to be done. And again, part of that was about training standards and potentially even a regulated qualification. And then all various other things, including things like prescription only, dermal fillers, etc. So things aren't going to get less regulated. They're only going to get more regulated as time goes on. Let's put it that way. So if you want to get involved in facial aesthetics, for those of you who literally haven't injected at all, the first thing is you need to determine this is something you actually want to do, because a lot of you would have been in practice, doing dentistry, and then this is obviously slightly different. So you need to find out whether this is something that you're interested in and you really want to commit some training to. So you can go on a short course, foundation training, to kind of get some understanding of what's involved. You might have a colleague who you can mentor and watch, and you can get an idea from them. So that's stage one. And then you're at a stage where you've done a course or two, you've been on, or you've seen a colleague doing some injecting and seen some cases, and you think, hold on, this is something I really like to do. Then you need to kind of plan how you're going to really kind of plan your training pathway. So I think at this stage, you need to understand what the GDC's kind of stance is on this whole situation. So there's not a huge amount on their statement wise, but they do state that if you do want to offer non-surgical cosmetic procedures, you must work within your knowledge and professional competence, adhere to the council standards at all times, and be prepared to back up the decisions you make. And this is quite my interpretation of that, essentially. So when it says you adhere to the council standards at all times, that's clear. We've got the 9 standards and we know what they are. But by the end of your training, you should also be able to work within your knowledge and professional competence and be prepared to back up decisions you make. So that's by the end of your training. So essentially, you need to consider these things when you're training. Number one is the clinical aspect. What are you actually doing from a hands-on perspective? So if you go on a course and there's no clinical activity, then you can't come out of that course and be competent at providing cosmetic injectables. And likewise, if you just go and do some mentoring and you literally have no understanding about the academia behind what you're doing and making evidence-based decisions, you can't back up decisions you're making. So a course has to incorporate clinical activity and academia, and then some of them rubber stamp with an assessment. So the question is, how much of each is required? So what you have to do is look at training standards, or like I discussed earlier, competency frameworks. So to make it kind of simplified, I've used implants as an analogy. So if you finished your undergrad training and you want to start placing implants, you can't just go on, you wouldn't just go on a day course and then start placing dental implants. You'd have to figure out, well, I want to go on a training program, and it's your actual responsibility to make sure that the training pathway that you embark on will meet what they deem as a standard that is acceptable. So what, for example, the FGDP did was they made training standards for implants. A group of highly experienced practitioners placing dental implants, they came together and the FGDP, and they made training standards. And so that outlines what you should gain as a minimum from your training, so that you could go on their particular program, but if you went on another one, you could at least benchmark that program against the FGDP training standards, so that once you've finished it, I'm at a point where I'm competent. Because the problem is that if you go on a course and someone says, yeah, here's your certificate, does that actually mean you're competent to actually provide those treatments? And the thing is, ultimately, the responsibility is yours. So you need to start questioning these things. So once you've sort of done that kind of training, you'll be in a position to start at least providing perhaps implants independently. And it's the same with non-surgical facial aesthetics. So if you want to treat, you need to think about your training pathway, and what you benchmark it against your training is the JCCP competency framework. It's accepted kind of framework in the industry. And again, it will have to contain some clinical component, academic component, plus or minus an assessment. Once you've done that, you're in a position to sort of treat. So what is actually required, or what do they expect? What's the expectation from the training? So ideally, you want to have observed and performed 24 cases of both dermal fillers and botulinum toxin. That's from a clinical aspect. And then academic is per the competency framework. So there's a whole list of items on that. And then, you may be, if, for example, the program that we're running with the college, we run various assessments, which then, having passed these, you then get the rubber stamp from the college. So that's essentially what you want to be doing. Now, like I mentioned, what you would want to do then is you look at your the JCCP competency framework, and then you look at what the specification is for the program that you've been on, and then you should really map it together. So what we did with the college is actually we looked at the framework from the JCCP, and then we compared it to our specification, and then we just added in the bits that we had not included, so that everything on our program maps against the framework. But there are other ways to do it. So you could go on short courses, but the question is, are you going to get those 40 cases under your belt? Is there sufficient amount of academia in those short day courses? And it's unlikely you're going to get an assessment or any rubber stamps. The other way you can do it is mentoring. So you might have an experienced colleague and you can do the clinical component with them, where you observe them and then they watch you treating a number of cases, and then you can go on a university program, which is fantastic for academia, but they're not competency-based programs. So a lot of misconception is that you go on a university type program where they do no or very little amount of injecting, and you're in a position then to actually inject. The thing is, you're not competent at that stage to inject, because you've not actually done any hands-on clinical training. It's like going through dentistry, going to all the lectures, going to all the presentations, everything, but just not doing any actual clinical activity. You're not don't have any competence at the end of that. But if you supplemented that with mentoring, for example, then there's justification there to say, yes, we've got some level of competency, potentially. Or you can go on a competency-based structured program where it kind of covers everything in one area. So you don't need to kind of have two different things going on. And that's essentially how we've developed our program, to make it easy for the individuals that embark on the program. And then once you've completed the course, the good thing about going on a structured program, because you're doing so many cases, it just snowballs from there. It allows you then to transition into practice and then see the patients there. There's a lot of onus that a lot of experience that you would have built up, so it's easily then you can go into practice and just sort of transfer that across. So once you've done that, I mean, there's lots of other things it can lead to. So you can look at, once you've done some level 7 or postgraduate training, you can look at the complex zones, more complex zones of the face, other treatment modalities to supplement, for example, the skin. It will lead to other job opportunities, different locations and clinics, and then you can potentially get involved in teaching as well, which is quite nice. So just the current and future projections of the regulatory landscape. Currently, you're registered with GDC, so you have responsibilities as before. You have to be competent before you provide these kind of treatments. It's not relevant really if GDC deem it part of dentistry or not. Essentially, as soon as you see a patient, there's a standard. The standard of care is still applicable, and essentially in the future there is a push to make training as per this framework mandatory, and regulations, as I said before, will only get stricter. So it's better, if you want to get involved in these things, just to kind of plan it out from the outset in the right way, so it's just easier down the line. So I'm going to move on to part 2, but I think we're going to stop for questions before I do that.
So Chalpesh, I've got one question here, which I think you kind of answered, but I'm going to ask it anyway. Tazim asks that she's enrolled within an MSc program in facial aesthetics at Barts, facial medicine in Barts. Yeah. And yeah, as you said, university-based, so strong theoretical background, but little to no clinical component. You said supplement it with mentoring. What other kind of options would you recommend to Tasneem?
Yeah, so to be honest, the reason I put that into presentation is because there's a lot of people in her shoes. And the thing about university programs is that you naturally go on, if a course advertised by a university says this is for non-surgical facial aesthetics, cosmetic injectables, you just naturally assume by the end of that program, you're going to be in a position to be able to deliver those treatment modalities. But in reality, the thing about universities, like you're saying, it's highly academic, and there's no clinical activities. So what we're doing at our academy is that we do the mentoring session. So essentially, the clinical component, the academic component is completed with the university, and then students come to us, and we do one-to-one mentoring sessions where they both observe, and then they can treat cases with us in our clinics. And that is essentially the only way you can build up some clinical experience. It's like once you finish an implant program, you might not be ready to kind of, even at a university, you might not be ready to place implants on your own. What you'd probably do is you'd have your patients coming in, and then you'd have your mentors coming in to kind of help you, and you build up a portfolio of cases, etc. And then when you feel comfortable, you'll then transition to working independently. And it's similar with this, but the difference is that generally in facial aesthetics, it works better if you actually come to our clinic, for example, because we have lots of patients, and it's just easier than getting someone to come and see, but you can do that way as well.
So, Jalpesh, another question that comes to mind is you talked about the 20 cases that you observe and the 20 cases that you kind of perform. Is that logged? Do you have to take clinic? Like, is there a logbook for that? And how does that look? What's that look like?
So are you talking about on the program, or are you talking about just generally?
In general, I mean, in terms of if we look at Tasneem, does she, for the mentoring aspect or the aspect, the clinical aspect, she would need a log of those cases, 20 observed and 20. How is that logged? Is there a kind of formal pathway around that?
No, I mean, it's not, to be honest. There's no formal pathway, but it has to be a reflective log. So it's all this stuff is, to be honest, is not mandatory, but it's what is deemed appropriate, because if you don't do these things, the question is you can't kind of justify treating independently. So the way I would log it, and the way we log it in our programs, for example, is you'd have your case, the clinical records, case pictures, clinical records, and a reflective commentary. So reflection essentially. And then obviously, if you're actually doing the treatments yourself, you'd want to have some reflective commentary and a signature from the person that's mentoring you essentially.
So bottom line is that you're saying that at the moment it's not mandatory, but it makes sense to make that log, because and if it becomes mandatory, you've got that ready for that accreditation process, whatever that looks like.
Yeah, I mean, also medicated. I mean, not medicated, but like even if, I mean, touch wood, this doesn't happen to any of you, but if there was a case, the question you have to ask yourself is, what would the GDC stance be on this? If you haven't, or you've done very little clinical activity and you're injecting on your own, they might not be terribly happy with that situation. And at least if you do something like along these lines, you're kind of following something that's been adopted by a body such as the JCCP, which they have a memorandum of understanding with. So they kind of, like I said earlier, they're kind of on the same playing field. They kind of understand each other, and so I think that it's a wise thing to do. And besides, the other thing is, in all honesty, putting all these kind of tick boxing exercises to one side. The question is, I don't think many people feel overly comfortable having seen maybe one or two cases to suddenly just be treating on their own. I think that's a reasonable number of cases to get through in a mentored situation to then feel like, yeah, I can actually do something on my own to a good standard.
Yeah, I've got one more question, and it's in the chat. She started a master's degree in facial aesthetics and hoping to register summarizing. So she's a qualified nurse and started masters in facial aesthetics. Can she work as an aesthetician, if you want to call it that, here in doing non-surgical facial aesthetics? She's a qualified dental nurse.
Yeah, I mean, ultimately, so with the dental nursing, ultimately anyone, whether you're a medical professional or not, can provide non-surgical cosmetic injectables. Now, so dermal fillers, anyone can get hold of it. It's not prescription only. Anyone can get hold of that. So that's dermal fillers. The question you have to ask yourself with dermal fillers is, if something went wrong and you need to use, so when we go into vascular occlusions, you'll in the complications bit, you're going to need to get hold of hyaluronidase, which is a prescription only. So there needs to be some sort of affiliation with a prescriber in an ideal situation. The second thing is botulinum toxin. That's prescription only. So there's no way you can get hold of it without having a prescriber on board. So yes, the dental nurses can definitely provide the treatments, but they need to also figure out those two aspects. Like if they're going to provide botulinum toxin, how they're going to get hold of that. And the way to do that is they'll need to find a prescriber that's happy to prescribe, but the prescriber will take on all the responsibility. And then the second is the hyaluronidase. That's a prescription only as well.
Fair enough. No, thanks for the answer there. Okay, I'll let you crack on.
Great. So part two, clinical cases. And we're going to be looking at the clinical aspect of the patient journey. And as I said before, I think a big focus is on how to generate patients to come, facial aesthetic patients. But the other thing about you've got to realize is that facial aesthetic patients, they come back for repeated treatments. It's not a one-off. You know, botulinum toxin, 3 to 4 months only last that long, so they'll be coming back repeatedly. And then dermal fillers last longer, but there's potentially a lot more indications or areas and that can be treated. So the question is, how do you actually maintain and grow the kinds of treatments that you're doing on a patient? How do you maintain the list as well? So that's what you're doing in the clinic. Essentially, is going to help massively. So you've got your consultation, facial assessment, treatment planning, and the injecting itself. So the first thing is consultation. Now, this is for me two things. One is red flags where I think I'm not too sure if I want to treat that patient. Doesn't happen terribly often, and I think it also depends on your demographics. So that's one thing. And then patient knowledge. There's an assumption that patients know everything, I think, but in reality they don't. So when we're looking at the medical history, obviously there'll be relevant contraindications for both botulinum toxin and dermal fillers. Clearly, those are red flags. And then what you'll find, a lot of patients, they come in and they'll have specific concerns. So they will say, I'm not overly happy with my frown lines and my forehead lines. And, the question is that because that's the only area they think can be treated, because it's such a common area that is treated and, lots of people have that particular area treated? Or is it because they just don't realize there's other things that can be treated as well? So you need to find out. You need to find out whether they have, is it actually just that only their only concern, or is it actually a global issue and they just didn't realize that other things can be done? And the reason for that is because if you don't find that out, you're limiting yourself to only treating a specific part of the face. So you need to find out you can do things like, for example, to do that, you can do things like pre-questionnaires. So before the patient even comes through the door, you can have a questionnaire, and it can have a picture of a face and say, little boxes with tick boxes next to things like frown area, forehead, tear trough, cheeks, etc., and you can ask the patient to tick which area is causing concern, and then they might think, oh wow, I didn't realize that could be treated, and that did concern me. And so all of a sudden you've got potentially more concerns than than they would have had initially. And in reality, the face doesn't just age from one part on, the whole face ages. So we need to look at the whole picture as opposed to one specific area. Now, that's not to say that some patients might only want something specific treated, and that's fair enough. So that in itself will start separating you from the average, because most people, if they came in and said, oh, I've got some frown lines, okay, fine, I can treat that, and off it goes. And that's really not the way to do it. You can find a tactful way of asking patients as well. So back to red flags. So then you want to be asking what the patient's trying to achieve and why, and you're sort of trying to kind of filter out the patients that potentially have lying on the spectrum of body dysmorphia. So for those who basic individuals, then there'll be some that have a particular concern, but the amount of emphasis that they put on it is unreasonable. It's beyond what you'd expect for the actual issue. So if their expectations are incredibly high, or they're putting onus on what you deem to be quite a small issue, you need to start being mindful. Timescales, patients that are in a hurry, always be careful, especially if there are big events coming up, and especially if you've not seen them before, because the worst thing to do is treat, and then you don't have a great outcome, and then they've got a wedding, and it's all becoming very stressful. So don't ever feel like you're rushed into something. Details about previous treatment. Always ask about why they left a previous practitioner and how many have they done that repeatedly. If they've done it repeatedly, it's highly likely. Not all practitioners are awful. A lot of them are very, very good. And it's highly likely that their just expectations are very high. And if they're just practitioner hopping, that's probably the reason. So they just can't, there's, as I said at the beginning, there's a finite amount that Botox and Dunflex can do. And then beyond that, that in terms of what they're looking for, it might be out the scope of those treatment modalities. And then just find out things like were there any complications, what products were used, do they understand what was done? Do they know what they had and why it was done? And I find that the education process of teaching, sort of making a patient, excuse me, aware of what these treatment modality, what these injectable treatments do, they kind of become, it actually helps build rapport, because once they start understanding, it's easier then to explain what other treatments can be done as well, or other treatment areas can be treated as well. So we're going to go through the facial assessment for this particular patient. And her main concern when she came in was her frown and forehead lines, and then lip volume. So we could easily have to be fair, she has indications for those things. And so we could have just sort of said, right, fine, let's just treat those. And that'd be the end of that. But ultimately, like I said earlier, we kind of discovered that she actually she wanted a more of a global assessment, and she didn't realize that other things could be done. So you might be thinking, well, I'm an early practitioner. I only know how to treat a specific number of cases. A specific number of areas. Is what you can do is you can have an understanding of treatment indications globally, although you can't treat all of them, and then you can phase your training accordingly. So say this particular patient came in and you could treat those areas, her frown and forehead and her lips, for example, that'd be great. But you could also conduct global assessment and say, look, there is indication for X, Y, and Z. And then once you've done more training, when this patient comes back, you can then, treat those areas. So when you go for training, it's really important, because the way a lot of training is organized, it's very limited in terms of delineated in terms of the parts of the face. There's never really a global picture. Is always sort of, course 1 is about this area, and course 2 is about this area, and course 3 is about this area, and then you kind of build like that way, as opposed to there's a whole patient on the chair here who's potentially got a number of different clinical indications. So even though you're early stage and you're looking at training in one particular area of the face, always ask the trainer, well, what other clinical indications are there? What other things would you treat if the patient was looking for advice to do so? And then that way you start to figure out, well, actually I could potentially treat this, treat that, and then down the line you can plan your training accordingly. So when we run our foundation courses or our advanced courses and our level 7 program, we always make sure we do a global assessment, despite the fact that we might not be treating all of those potential areas. So I think that's quite important. So what you're looking for, so this is just a really broad, like high level kind of facial assessment criteria, things that you should be looking out for in a facial assessment. So this is not in detail, but just to give you an idea, and then you can, once you get into the nitty-gritties for each of these little areas, then it becomes a bit more fun, and you'll get much more holistic approach to kind of treating this patient. So you're looking at the overall facial shape. We look at their facial proportions, the facial contours, asymmetries, areas of volume loss, static dynamic lines, facial profile, skin quality, and individual characteristics. So I'll go through these in a bit more detail. So when we're looking at overall facial shapes, different types of facial shapes. So generally, we in a female patient, for example, we would have an oval shape, and that's a feminine characteristic. And you have the prominence at the cheeks, and it comes down to dainty to chin, and you've got an oval type shape. Now, when you've got poor cheek definition and sort of prominent masseters, for example, the facial shape becomes squarer, and that's more masculine in appearance. And so what do we look to do? We look to slenderize the masseters and add a bit more definition to the cheeks, and then you got a bit more of an appearance that's sort of more synonymous with the female. Facial proportions. So we can split the face both vertically and horizontally into thirds. And there are things, that can be done to improve these proportions. So, for example, if the patient was lacking in the lower third of the face, we could augment the chin to actually create more length to the lower third. Similarly, if they were lacking laterally, you could augment the cheek. So there's various things that can be potentially done to actually help with facial proportions. But there's tons of things, but I can't really have time to go into it in a lot of detail, but that just gives you an idea. And then we look at their key structural features. We look at the key structural, these are the components of face which can be augmented to create more definition, more pronounced structural changes. So things like the cheeks, the angle of the mandible, the chin, and the lip border. So these are things. So these are kind of areas where if they're over treated, that's where you get these kind of situations where things are looking a little bit abnormal. So this is where your sort of ethical boundaries kind of come in, and you have to think, well, what looks natural and what doesn't, and you need to kind of stay on the right side, essentially. And then the true indications, like the areas of volume loss. So patients get sort of, in this particular case, your sort of temporal hollowing, the temples, loss of volume underneath the eyes, tear trough formation, the anterior cheek becomes flatter, and you lose volume. You get the malar fat pad, which the cheek fat pads come down and herniate against facial ligaments and creates these sort of nasolabial folds and marionette lines, which then lead to sort of sagging as well. And then you've got loss of volume in the lips, so inversion of lips over time. So we're looking at these sort of various areas. We're looking at asymmetries in this particular case. She hasn't got very many asymmetries. This is a case that we treated where there's a palsy on one side, and this is just a little bit, we've got to do more treatment for her, but essentially we actually put toxin in one half of her face to kind of balance it out with the other. So that's another thing that can be done. But look out for asymmetries. Facial contours, various facial contours, one of them being for example, the jawline. We're used to having, in a youthful presentation, a smooth, continuous, uninterrupted line for the jawline, for example. Whereas with age, you start to get some sagging, and then you get this, what we call so the sagging is called jowling, and then you get what we call a pre-jowl sulcus, or essentially a deficiency in the area in front of the jowls. So it's, although you may not be aware of it, but subconsciously this is a thing that you'd look at, and that's what trigger the thought that this patient is looking more aged, for example. So smoothing it out kind of makes the patient look less aged. We've got to also appreciate the facial profile. So I think what can end up happening, you're looking front on patients. A lot of students just look front on, but the actual thing is you've got to look, it's a 3-dimensional situation. You've got to look obliquely, laterally, and there are various features that we can look at from a profile situation and help in that respect. So the way the lips and the chin and the tip of the nose kind of line up. And if we feel like they're not in the balance that we want, so we normally use this sort of Ricketts line or a similar type line to kind of delineate that. You can augment accordingly. So we did a static facial assessment for this lady. And, she's got some sunken temples, she's got some nasolabial lines, inverted lips, so thinning of the lips, some jowling, some blunting of the jawline. She's got a wide chin, so generally speaking, a wide chin is more sort of attuned to a masculine type feature. And then you've got dynamic facial assessment, which she has got frown lines, which is her primary concern, one of her primary concerns, and forehead lines and dynamic lateral canthal lines, or crow's feet. We would look at her skin quality as well. So, it's out of the scope of this presentation, but things like pigmentation and fine lines, that's another thing which, again, she didn't realize that can be treated. And so we come up with a situation with treatment objectives and recommendations. So you've got oval face, no major asymmetries. So you've got temples, lips, and nasolabial folds with areas of volume loss, and facial contours are affected in her jawline. There's been some blunting and jowling, dynamic facial lines, forehead frown and lateral canthal, and profile assessment, chins lacking some anterior projection. She's got pigmentation, fine lines. So these are recommendations. We want to restore volume, improve facial proportions, recontour, soften the dynamic lines, and then hydration, improve skin texture. So that is very different situation to what could have been the situation if we just went with her original concerns. So you need to get consent, and the treatment objectives were here, and so the treatment options, you discussed them. They're things like dermal fillers, botulinum toxin, skin treatments, and you need to kind of make them understand, because if they're having their temples treated, they might think, well, what effects are going to have? You can use pictures, you can draw, you can show them a mirror where there's deficiencies, etc. Use previous cases to kind of illustrate. Get informed consent is clearly very, very important, because there are risks associated with these treatments. And then give them a cool-off period. Like, at the end of the day, if you're treating a number of areas, you need to even if you're not, even if it's just a small number of areas, you should really give them time to think about what they're having done, especially if they've never had it done before. So it's very important to give them a cool-off period to let them digest everything that you've discussed with them. So in this case, we're going to reduce her dynamic frown line, forehead and lateral canthal lines. We're going to reduce temporal hollowing, some chin anterior and inferior projection, labiomental crease softening. So that's the crease that lies between the lips and the chin. Give some mild lip definition and volumization. Soften the nasolabial folds. Actually, I don't think we end up doing that. She didn't want that in the end. And pre-gel sulcus and jawline definition. So we'll start with botulinum toxin. So for those of you who are really very, very complete novices, don't worry about this too much. Just start to get an appreciation of what the difference is between the way we treat Botox and dermal fillers are. But and for those of you again who are injecting, when we injected this particular case, we used Azulure, but for those of you using things like Botox or Berkature, Botox, the dosing is different, so you can't. These aren't synonymous. So please don't just go and replicate what I've mentioned here unless you know what translates to what. So the frown lines are created by this muscle, the procerus, and then and also your corrugator, your lateral corrugators. You got your forehead muscle, your frontalis, which creates the forehead lines. And to relax these muscles, we use 5 injection sites. And when we're doing Botox, when you're starting out Botox, you need to use landmarks, bony landmarks, ideally, to determine safe zones. So generally speaking, when you're working periorbitally, you want to make sure you're 1 centimeter away from the orbital rim. In this particular instance, you can use, for example, the medial canthus for this point. You can use the mid-papillary line for this point, and then an intersection for this fifth point. And then you can have evenly placed spread of toxin across the forehead, again using landmarks. And with what you need to know is obviously the location. You need to know dose and depth. If you know those 3 things, you can pretty much treat anywhere in the face with botulinum toxin. If you're missing one of those things, you can't. So you need location, dose, and depth. If you know those things, you're pretty much good. So location, for example, I've just outlined how you'd get the locations for those areas, but ultimately it's where the muscle is active. And the locations have to be safe as well, clearly. And then dose is dependent upon severity and location, and depth is dependent upon how deep the muscle is, because we're relaxing a particular muscle. So, for example, the frontalis is superficial. There's not much space between the skin and the bone, so these are superficial injections. And in fact, what I'll do is I'll just go to the next slide, go through the crow's feet, and then I'll go through a video of the injection itself. So crow's feet, lateral canthal lines are sitting around the lateral aspects of the eyes, and they're caused by orbicularis oculi. And you can use 3 sites. If it's severe, you can add more sites lateral to those initial ones. And again, it's a superficial, these are all superficial type injections. And you can see a drawn illustration of the orbicularis. So this is injections of the forehead. And as I said, this is a superficial injection. It's not going deep. And it's just 5 points across the forehead. There we go. And then again, crow's feet, superficial injections. Sorry. Okay, sorry. I should the procerus and the lateral corrugators weren't on there for some reason. So just to kind of highlight, if you were going to inject into the procerus, it's a deep injection, almost down to bone. And then the head of the corrugator, so the most medial point, is a deep injection as well. But the tail of the corrugator, which is the most lateral point, is a superficial injection. So that's sort of what you'd be looking at for with toxin. Then we're looking at dermal fillers. So again, we need to respect the anatomy. We use, again, bony landmarks to determine where we're going to be injecting. So again, you need to know location, depth and volume. The other additional is product selection as well, and technique. So when we're restoring volume to temple region, it's down to bone essentially. And we need to understand the relevant anatomy around it. There are superficial and deep temporal arteries. And we use a high viscosity product such as Juvederm Voluma. So for those of you who aren't aware, generally dermal fillers come in different in different viscosities. So essentially you've got softer products, and then you've got products that are give more projection, things like that. So essentially Juvederm Voluma is something that does that. It's more volumizing. Whereas if you're treating soft lines like around the lips, you want a softer product such as Voluma. Now each brand will have different subcomponents, so you just need to find a synonymous one. So we use 0.5 mils either side, and there's using a needle. So the difference over here is that we're if you look, I think you'll be able to see it. There's an aspiration first, and then there's an injection. So aspiration is a little bit contentious into controversial. Not everyone does aspiration, but I think it's good habit to get into if you can, because I've had positive aspirations. And the thing is if you inject into a blood vessel, you're going to get an occlusion. So it's best to aspirate and then inject once you've done that. So this was 0.5 mils either side of Juvederm Voluma. So again, we're looking at the chin now. So it's an injection down to bone again, and you can do that over 3 sites potentially. And anatomy, mental artery, if you're too lateral, you have to go quite laterally for that to occur. And you can use something like Juvederm Volux, which again gives quite a lot of projection. It's not soft. And again, needle technique. I think on this one, there's you can see the aspiration that they're being done. And ideally, you should wait a couple of seconds. And then you want to inject. Then if you inject the chin, excuse me, and you get projection in the chin, you might accentuate, well, a lot of people have this anyway as part of the aging process. As you get inversion of the chin, you get this labial mental crease. So you can inject this as well to soften that, because you'll find if you start looking carefully, as the patient ages, they start to develop a little line in this area or depression. And it's nice to soften that, so the transition from the lip to the chin is not so delineated. So again, but this time we're going to be looking at a subcutaneous, so we're not going deep. We're using a slightly softer product, Juvederm Volift. Again, mental artery is quite far out. And we're going to use a cannula this time. So that's different to a needle. So what you've seen before with needle injections, this is a cannula. So with a cannula, you have an entry needle, which creates a point for you to insert a blunt-ended cannula. This cannula is blunt-ended, so it won't perforate the skin, so penetrate the skin. So you need to create the entry with the needle, and then the beauty is that once it's subdermally in the subcutaneous, the tissues aren't as dense, and you can actually then just move the cannula around. So you've got one entry point and you can inject quite a lot of product over a larger area. And because it's blunt-ended, you're not traumatizing tissue and blood vessels as you go through. You're pushing it to the side, so the patient's less likely to have pain. So this is no local anesthetic here, by the way. No anesthetic. You're less likely to get bruising and swelling, post-operative swelling with the cannula. So cannulas are a really nice thing to use. So that's 0.5 delivered via cannula. Softening nasolabial folds, again, subcutaneous, so not deep, using a cannula, but it's actually a higher risk area because there are the facial artery and the angular artery in the vicinity. And using a medium viscosity product, your entry point would be where these dots are, and then cannula advance along the fold. We'll go into the details of this later on, but essentially you have your facial artery, which if you palpate just anterior to your masseters, the anterior border of your masseters on the lower border of the mandible, you'll feel a little notch. And there you'll be able to almost be able to palpate the facial artery, and then it sort of follows this tortuous pathway and gives off the inferior labial artery and the superior labial artery, and then runs up almost alongside the nose, and you've got your angular, it kind of turns into angular artery, and it anastomoses with sort of ophthalmic arteries as well. So that's important because if you were to inject into this vessel, you've got potential sort of retrograde flow of the filler into the ophthalmic artery, which can be quite a severe consequence, but incredibly rare. But if that happens, it's quite a severe consequence and can lead to blindness. So although there's very, very small number of cases, shouldn't make you scared or anything like that, but it's just to kind of, again, emphasize there is a risk profile associated with these things. So then the pre-gel sulcus, which is basically the kind of the sulcus that sits just in front of the gels. Again, it's a subcutaneous injection, which we use Volux, a high density, high viscosity product. Again, using a cannula. So it just gives you an idea of the versatility with the cannula. You can be used anywhere on the face almost. And so once we've treated the pre-gel sulcus, you can actually then, what you want to do is avoid that area where it's been marked red, because you just make it look worse, to be honest. Because the jowling, you don't want to add to the effect of the jowling. And then again, for jawline definition, you can use a cannula, 0.5 mils either side in this particular case, using something like Volux, and you're concerned about the facial artery again. So that's why we stay superficial and we're using a cannula. And you can almost make these kind of linear threads with the cannula to kind of make the jawline more pronounced. And then some mild lip volumization, definition and volumization. She had some decent volume to her lip, so you don't want to put too much in. So you got to be mindful again of the superior and inferior labial artery in this area. And we used Volift, which gives a bit more projection and volumization than a softer product, and use the needle to do this. So you've got your before and after with the lips. So that was a case. So we're on to part 3. I'll invite Mish back into the, if there's any questions, if he's there.
I am. The questions are not flowing at the moment, but I think that's because of the videos and just showing things. So that was really good. In terms of actually doing these kind of cases, how long do you feel, just out of my interest, because as a periodontist and implant dentist, it takes a long time to kind of get into doing these kind of things on a regular basis. When you're doing these kind of cases, how many do you think that you have to do, say, a month to feel like you can constantly deliver it? I'm speaking from experience, given that back in the day, I did some facial aesthetic courses and then did it a bit and then didn't get around to doing any more after that because I didn't feel comfortable. So is there kind of a number that you would look at and say, in fact, that's how many you have to deliver on any regular basis?
That's a tough question. I can't remember to give you a number. I think the thing about it is it's just it's a snowball. I think it's momentum, and I think, like you, there's many people that are kind of similar shoes to you. They go on a few courses and they might do a couple of cases and then it just kind of peters off. You need to build that momentum. I can't give you a number of cases.
And any advice on building that momentum? Because we've just gone through some clinical cases and, I was surprised by the fact that cannula, no local, you would, in there. So can you tell me a little bit, just how do you gain that momentum? I mean, I know you just do cases, but how is there any kind of help that you can give to people watching?
So I think the key thing, is, well, that's why part 2 is really important, because a lot of people focus on getting patients through the door, and then they're not really thinking about once I've got the patient here, what's going to happen to them long term. They're just thinking about do the treatment, get them back out again. And the thing about it is that patients aren't going to come in. That lady is not going to just come in. Well, they might in some places, but not everywhere. They're not going to just come in and suddenly have a whole heap of treatment done, having not ever met you before or whatever it is. It's a staged process. So when you're starting out, the things that you've trained in, for example, I'm assuming, Mish, you probably did some upper third of the face Botox, maybe a little bit in the lips. I don't know, that's the kind of thing that people do to start with. And patients coming through the door. Now, if you treat those areas and you build that list, doing those things, but are aware of all the other potential indications, it can really help you kind of then move from that point to a point where you can kind of say, well, I know that these patients, and you should actively make a list. Like, facial aesthetics, you need to have your own separate list there. Who the patient is, what their indications are, and what you've treated, and then I've got these 6 patients who actually probably could do some cheek fillers, and next time when they come in for their Botox, I'm going to say, well, have you thought about some definition to your cheeks? And they might say, well, not too sure. And then the following time they'll say, actually, I want to consider that. And in that time, you need to consider your training. Well, I'm going to do some more mentoring in that particular area. And then when they come back, you can treat, and then you're going to inject more and more as a result. I think what happens is you kind of, you can't, people don't know how to progress from just the basic kind of doing the basic kind of toxin to the upper third of the face to the point where there needs to be a plan in place like that. Almost, you've got to tie in training what's happening in your surgery, in your practice.
So what I'm kind of hearing is that you look at patients holistically, but do what you can, but be aware of what you can't, and then get training on what you can't, and do it on the same list of patients, given that they're going to be coming back every 3 to 6 months or whatever.
Yeah, give them a really good. I mean, all my patients, before they come in, they'll get a pack, introduce them to the practice or the clinic. And then afterwards, they always get a follow-up email saying, I hope it went well, any issues, etc., please contact us back. Just little things, because you want to maintain those patients. And when you do, they're coming back to see you regularly. It's like in dentistry, to be honest, because you see a new patient and they might have a few issues and you point them out, but they're not too keen to get them sort of addressed. How many times do they come back after they've seen you a few times and say, actually, you know what, I need to get this sorted out? Or you mentioned that the shade of my teeth, it could potentially be improved. And actually, I was thinking of doing that, or whatever it might be. Or, people, they do come back to you, but you need to build that. I think that's really important. And then it is a kind of a snowballing thing. I don't think it's the number of patients you have that's going to determine how well you do. It's to do with the rapport you have and the number of quality patients you have. So it doesn't matter if you're having, even if you have 10 times the number of patients coming through the door, if you're not developing that rapport and kind of understanding what they might need in the future, it's hard to then, I think, anyway, that's how it's worked for me. But, everyone's slightly different.
I'll let you crack on with part 3 then.
Sure. So last part, vascular occlusions. Excuse me. Vascular occlusions. There are different complications with both Botox, botulinum toxin, and dermal fillers. But I think one of the ones with dermal fillers that we need to kind of keep refreshing our minds about is vascular occlusions, because they don't happen commonly, but when they do occur, you need to know what you're doing. And I guess it's the same as, a medical emergency. They don't happen that frequently, or hopefully they don't happen at all. But when they do, you need to kind of know how to play it out. So it's the same with this. So essentially, a vascular occlusion is when you obstruct a blood vessel. So you can inject into a blood vessel, disrupt the blood flow, or you can inject a sufficient amount of product that effectively compresses a blood vessel and disrupts the blood flow to a particular area. So that, if left, it can lead then to skin necrosis, because if there's disruption of blood flow to a part of the face, then tissues aren't getting nourished, and necrosis. And the relative risk depends upon the region of one of the things is the region of the face. So some areas have higher risks than others. So the incidence of necrosis for dermal fillers is 1 in 100,000. It's not common. So that's the incidence of necrosis. Okay, but in reality, it's probably more than that, because it's underreported. So high areas of risk are in the midline, i.e. the glabella in the nose, and the nasolabial area. High in the temple, tear troughs, and medial cheek. Moderate in the lips, periorally around the mouth, and anterior cheek. And then there's lower risks in the lateral cheek, marionette area, the jawline, and the chin, and submalar. And so what you want to be doing when you're injecting dermal fillers, you've obviously got to be paying attention to what you're doing in terms of the actual injections, but you've got to be considerate of the surrounding areas and what's happening with the patient. So severe pain is not associated with dermal fillers. The patient you're injecting and the patient is getting excruciating pain, either at the site or a distant site, because you can inject a product and it can move. It can become an embolus almost. It goes down the blood down the blood vessel, and it can go to a different site. It can cause a lot of pain potentially, not always, but it can. So that's one site. Blanching. If you disrupt blood flow, you get blanching, and so there's some pallor, whiteness, and it can then lead to a dusky type appearance quite quickly after. So if you start to notice these things, so changing color, you need to be thinking, well, is there an occlusion here? There could be some level of coolness, and then delayed CRT, so capillary refill time. So that's when you, for example, if you put pressure on your skin for a couple of seconds, you release, the color returns very quickly. Now, if you have delayed that in a delayed situation on the face, then there's probably potentially an occlusion. So the stages are, like I mentioned, the first thing you'd notice pallor, and then you'd notice some purple duskiness, and that is essentially after sort of minutes. And that's because you get an accumulation of sort of deoxygenated blood. And then after, sort of 72 hours or so, you're going to get pustules. You're going to get sort of facultative bacteria that are sort of creating these pustules. And then you're getting coagulation and necrosis sort of setting on after that. So there is time to work, but you need to ideally be quite vigilant and act as quickly as possible. So if you suspect a vascular occlusion, you need to obviously stop treatment straight away. You then want to assess the capillary refill time. So there's a few ways you could do that. One is you could actually figure out what the capillary refill time is before you inject, so you know how long it takes for the color to return once you've pressed on it for a few seconds. The other way is, if you haven't done that, you can compare it to the unaffected side. But basically, if you think it's sluggish but less than 3 seconds, but it's less than 3 seconds, just try massaging, tapping, application of heat. But if there's no improvement in that CRT, or it's greater than 3 seconds, you need to then go to step 2 quickly. And the key step is the hyaluronidase. So hyaluronidase, basically, I should say that this only works on hyaluronic acid based products. Okay, so a lot of dermal fillers, most dermal fillers are hyaluronic acid based, and you can use hyaluronidase, which is the enzyme to sort of dissolve the product, and you use a system called a protocol, the high dose pulsed hyaluronidase protocol, to dissolve the product. And it can prevent necrosis in most cases, even up to 48 hours post treatment. So you have got time, but you want to act quickly if possible. So I've got a video of that, which I'll show you in a moment, of how to reconstitute that. But essentially, the hyaluronidase comes in a vial, and it's got 1,500 units in that vial, and you need to place 2 mils injectable saline into that. And then, so you reconstitute it with 2 mils of saline, and then you use a serial puncture. You inject the area where there's a suspected occlusion. You do that from 450 to 1,500 units. And then you repeat that every hour until you feel the capillary refill is less than 4 seconds, i.e. 3. And you can do that for 4 times. Or until there's resolution. Now, if that hasn't happened, then you need to basically seek help. But it should work quite quickly, to be honest. So this is just a video. So this is a video by the ACE group, which is actually a really good group, because the Aesthetic Complication Expert group, they have a really good service. If you're with them, if you have a complicated, they have a 24-hour line which you can contact. So that's quite nice to know that there's something like that out there. So what you do is you have a 5 ml syringe and a 1 ml syringe, and essentially what you're doing is you're drawing up the saline. So you'll see this in a moment. So this is in that vial, there's 2 mils of, not this vial, the one with the saline, there's 2 mils of saline, and this is the hyaluronidase that's just been opened. So you draw up 1 mil or one and a bit mils from there. So that's from the saline. And you pop that into the vial with a hyaluronidase. Now, the reason you don't put the whole 2 mils in there and then just use that is because if you do that, it will overflow. And then, so you only put about 1 mil in there. So what you do is once you've placed it in there, you inject and draw so it's properly mixed. So you can see that happening there. And then see it's been injected and drawn and pushed back in. And then eventually you would draw it out and you pop it back into that original ampule containing the saline. And then you just kind of, to mix it, you draw and expel a few times. So then you've basically got 1,500 units in 2 mils. So once you've done that, you've successfully reconstituted the hyaluronidase, and you're in a position then to draw that up with the 1 mil syringe and then inject via serial puncture to a number of areas around where you have the suspected occlusion. So that's effectively the protocol for hyaluronidase. Step 4 is aspirin. So you can, well, obviously there's no contraindication, you can give a 300 mil stat dose of that, and then 75 mils daily until the compromise is completely resolved. And these are the rationales. So you limit the platelet aggregation, clot formation, and further vascular compromise. And then if nothing's working, you need to refer to a specialist, essentially. So the question is, if you're doing, over the course of your career, you're doing thousands of these injections. So you need to figure out the way of reducing risk, because you want to make sure the number of adverse outcomes are kept to a minimum. So there are different ways that you can reduce risk of a vascular occlusion. So number 1 is anatomy. You need to understand your anatomy as best as possible. You need to understand the surface landmarks, bony landmarks, and then you need to be mindful of depth of injections and variations in anatomy, especially, for example, if they've had surgery that's giving you potentially lots of variations, so you might be a tricky case. But ultimately, it doesn't matter how much anatomy you know. There's blood vessels everywhere, and so the risk of an occlusion is possible, despite even if you know your anatomy inside out. Unfortunately, there's vessels everywhere, and there's variations. So understanding where key vessels are is important, but that can't be everything. Then procedural points that will help reduce the risk as well. So we talked about aspiration earlier. Aspiration is I think it's really important. Others query whether it actually helps or not, but I think it's best to aspirate if you can. inject slowly under low pressure, and use a blunt-ended cannula. So that will help reduce chance of entering into a blood vessel. Use the smallest possible volume to get the desired effect. So if you put that's one thing, but also avoid bolus injections as far as possible by injecting a large volume in a small one injection. You've got a higher risk of getting a compression of blood vessel or injecting a lot of product into the blood vessel in one go. Try and use hyaluronic acid-based dermal fillers, because then at least you've got the hyaluronidase you can potentially use to dissolve. Avoid areas where there's been previous scarring. You might get tethering of blood vessels, makes it easier to kind of inject into. And as I said, avoid bolus injections. Avoid adrenaline as far as possible. Again, that could lead to blanching, etc. If using local, be very mindful of using local anesthetic, because again, it's pain. If the patient is getting severe pain, you won't notice that if you're using local anesthetic. And if the patient's had facial surgery previously, the vessels were likely to potentially be in different places. So the risk can go up that way. And key thing is just pay attention when you're injecting. Look for if the patient's in extreme discomfort. You want to detect these things earlier. Look for color change, not just at the site that you're injecting, but also at distant sites as well. Looking out for pain and visual disturbances. If they're getting visual disturbances, that's something you need to stop injecting straight away. But again, it's highly unlikely to occur. So that's the end of the presentation, really. Just to give you a bit of info about what we do at Rasa Academy. We have a number of sites. And we do our flagship is the Level 7 postgraduate certificate that we run with the College of General Dentistry. It's to get either an absolute novice or a relatively new practitioner to a point of competence. So it encompasses a lot of things, including a lot of clinical activity, like the 40 cases that we discussed earlier, which you do at our clinics under our supervision. All the mentored cases, so the cases that you perform are done on a one-to-one basis. So it's really nice because by the end of it, you're feeling ready to go. We also do the bespoke mentoring sessions. So there, like we had the question earlier from the lady who has embarked on a university-based program, and there's a lot of people that have done that, but what they're lacking is the clinical experience. So we do the mentoring sessions when you come in with us, and we kind of inject the whole day. Just we have patients booked in the whole day, and we're learning on the patient injecting all day long. So you're getting all your academic bits from the university, and then the clinical aspect from us. And then also for those people who've kind of got a baseline level of competency and want to learn about different particular areas of the face. And then as tasters, we do foundation and advanced courses. These are just short courses. And our ethos is that we have experienced trainers, and we only have small groups. We never have more than three students to one trainer. So you get a lot of time with the trainers and on patients. So the days are very hands-on. Most of the day is hands-on. We do applied method of learning. So what that means is when we're looking at vessels and anatomy and everything, we're kind of just doing it on the patient as opposed to looking through loads and loads of slides. And we give guidance and help with how you're going to progress in your career, etc. So if you've got any questions from today or any kind of questions, very open to anything really, advice, etc., literally happy to help. You can go to our website, and then there's just details on how to contact. You can contact us there. We've got our Instagram handle here and Facebook as well. And like I said, if you sign up to our newsletter, we can on our website, we'll send you a video of a case that we've done. Great.
Yeah. So we've got one more question here. Agatha asks about tissue depression using hyaluronidase in terms of what you were talking about earlier. What are your kind of feelings on that?
Tissue depression, so does he mean once it's been administered?
Administered, yeah. So like the fall in of tissue, and how do you kind of modulate that?
So what it will do, it will dissolve the product. You're not going to get massive amounts of depression, but you do need to advise the patient there's going to be redness and swelling. So what you would want to do is, number one, if there's a vascular occlusion, you deal with that. And then once it's stabilized, you reassess. And then if there is areas where there needs retreatment, then that's fine. But, at that point, it's effectively an emergency situation where you just deal with that situation, and that's that. But you would have you should be consenting your patients to this beforehand, to say that, there is a risk that the filler can go into the blood vessel. If that happens, we have to dissolve the product, and that process can lead to X, Y, and Z.
Are there any other questions from the audience that people want to ask? Because we've got Jalpesh here. One other thing, in terms of your locations, there's Harley Street.
Yeah.
You run something out of Liverpool as well, right?
We have some that's our smallest one. So we do occasional clinics out of Liverpool, but mainly from Esher, Pinner, and some in Harley Street.
Okay, great. So those are the locations. In terms of this PG cert and level 7, do you feel it's going to become mandatory as we go forward?
I think that's a push towards doing that, because ultimately it just gets you to a point where you're going to feel comfortable injecting on your own, and you're going to be competent to do so. I think also I think the thing is, once you commit to something like that, it means that you're committed to actually performing that in practice as well, because you've invested in your education. So you feel like, I've got to then progress and actually use this in practice. I think the problem with like day courses is that you can be inclined to go on a day course or a short course, and then nothing will transpire from it because you haven't really invested much time into it. And also with what we're finding with our postgraduate students is that essentially we have so much time with them, because we have them for for a year essentially. We can really help them just build up the lists essentially and guide them. So there's different ways. I mean, in our academy, we've got, like, for example, I'm dental, and I do a lot of treatments in dental setting. But then we have another one of our trainers. She's a dentist, but she does a lot in skin clinics. We have a medic doctor who's been injecting for many years, and he's got his own private clinics. So we've got people with different setups, and we can kind of steer our students accordingly. And that helps, because some people want to work in skin clinics, for example, like with dermatologists, whatever it might be, or you want to set up a private clinic in a clinical setting somewhere, and there's what things to consider. So we've got kind of that commercial aspect kind of also ticked off, which we can do with our students over the course of the year. It's very difficult to do that in a short 1 day or 2 day course.
Yep. Any other questions? I think we've got most of that covered. So Jalpesh, it just leaves me to thank you for your evening and giving up your time. Okay. And anybody that kind of gets in contact with us in terms of the lecture today, we'll pass on details and so on. Thank you so much for coming down and giving us a really strong introduction to what you do.
Pleasure. Thank you very much. Thanks for having me, and have a nice evening.
You take care. Thanks a lot. See you next time. Bye-bye.